We've met already, Caroline. I'm going to pass over to Ruth to open the webinar.
Okay.
Go ahead, Ruth.
Thank you very much. Thank you very much, Caroline. A warm welcome to you all, and I'm so happy that many of you have joined us again. And to those of you who are joining us for the first time, we say thank you very much. It's going to be a very exciting session. It's a full house today. We've been running this webinar on behalf of the FAST package and the Nursing Now Challenge group. It's been on the Female Genital Schistosomiasis Awareness Creation session. My name is Ruth Alote, and I'm not here alone. You heard Caroline who spoke earlier, and then I have two other team members with me. Dr. Hamidat Omoyeli Abdusalam and Dr. Obechuku Aribodo. When I finish with my session, they will join us with theirs. Feel free and enjoy. Next slide, please. So this is basically about what we are going to go through for today. Next slide. Generally, schistosomiasis, it's something that affects both boys and girls, men and women. But today, our focus is going to be on female genital schistosomiasis. It's a neglected tropical disease, and it affects a lot of people. A lot of people are really suffering from this. About 56 million people are already suffering. And this is why it is important for us all to join the team to create awareness and let everyone hear about this menace. FGS is one of such NTDs that affects millions of women. For instance, in sub-Saharan Africa, we are in an endemic area. Ghana is not left out. Nigeria is also one of the endemic areas, and we have many more. And as we go through the slides, you hear stories about why it is important for us all to join this fact. Next slide, please. A lot of awareness has been created already. This is the 4th session, and we want us all to join in the challenge to bring out an idea to create awareness on FGS. It is also important for us all to pay attention and get the knowledge, the facts that is about FGS. And I will encourage each and every one of us, don't just stop by hearing the information. Try and pen your ideas down and submit to take part in the challenge. Next slide, please. Now, let's look at the slide. There's a scenario about a 20-year-old female in a rural village in Ghana who loves to swim. You know, for us in Ghana, during holidays, most of us who even live in the urban areas go to the villages to be with our grandparents. And there we go to the riverside, we help with the house chores. We love to swim in the rivers. But this young lady comes with some symptoms weeks after returning from the riverside. She has genital itching, burning sensation, bloody urine. There's also lower abdominal pain. In a minute, kindly send your message in the chat. What do you think this is likely to be? What disease condition would you have thought of? Maybe in this day and era, could it be rape? We just want to know what your thoughts are. If it's the first time you are joining us, it will be great for us to know. This will also help us to improve on our subsequent sessions. Okay, so at this juncture, I want to move on to the next slide. FGS is so relevant in this day and age because when you look at the number of people who are suffering, especially girls as little as 10-year-olds are involved in this menace. It's so sad for a girl or a woman to just go about his or her normal daily activity and comes down with a disease called the female genital schistosomiasis. Usually we have different species that is causing schistosomiasis, but the one that is of essence when it comes to female genital schistosomiasis is the Schistosoma hematobium species. So you can see on the map of Africa, all the red spots that you see are very endemic areas. 56 million people are already suffering, and this includes women, our loved ones, and little girls that should be in school, but might have been challenged and sometimes are even in the house due to circumstances that they are going through, due to infections, due to anemia, due to signs and symptoms that they can't even bear with. They stay at home and can't even go to school. So that is why it's so crucial for you and I to join in this awareness creation exercise. Next slide. Now, how does FGS occurs? It's actually a cycle and usually starts with someone who is infected, gets to a nearby stream or a riverside, any freshwater source. The person urinates or defecates into the river, and then the eggs are released into the water. When the eggs are released, they are hatched. And there's an intermediate host, which the snail, special type of snail, harbors this. So within 4 to 6 weeks, they get matured, and these larvae are released back into the water. Any other person who steps in the water, maybe to swim, to fetch water for a household chore, to wash in this river, get exposed and are likely to be infected with the FGS. This is how the cycle goes. So usually it's not something that you have to go and pick it from someone else, but just because maybe you're on holidays, you decided to travel to a riverside in one of the African regions, and you can end up with female genital schistosomiasis. Any contact with a freshwater that is infested with the Schistosoma hematobium species, you are likely to get female genital schistosomiasis. It is widespread in Africa and in most rural and urban areas. For us in the urban areas, we sometimes have people traveling from the rural areas and settling in the urban areas. So even though we see the rivers within the urban areas, we are still likely to have cases within urban centers. It is transmitted only by skin-to-skin contact with infected fresh water. As I said earlier, it is only when the worm lays eggs, which are deposited in the organs of some of the women. So when you get into contact with the water, the eggs penetrate through your skin, and it can travel to your organs, including the female genital tract, anywhere, the vulva. It can hide anywhere within the tract, and later it causes changes within the cervix, and this leads to several complications, including infertility, ectopic pregnancies, spontaneous abortions, bleeding tendencies, and usually are misdiagnosed. Next slide, please. So how would you notice if someone has female genital schistosomiasis? Usually the female or the girl may present with bloody urine. There could be genital itching or burning sensation at the vaginal area. There could be a discharge. Sometimes the discharge could be bloody. bleeding after sexual intercourse, especially within sexually active females. There's usually pelvic pain or pain during and after intercourse. Next slide, please. For us to diagnose female genital schistosomiasis, actually, it's been very challenging. This is because the signs and symptoms mimics other disease conditions, and this makes it very difficult. However, when urine test is done, the eggs are likely to be seen. Also, you find grainy sandy patches and homogeneous yellow sandy patches or rubbery tubercles when a colposcope is used. Next slide, please. As I said earlier, differential diagnosis of female genital schistosomiasis includes pelvic inflammation disease, cervical cancers, postcoital bleeding, and persistent vaginal discharge. Next slide. Why is it difficult to diagnose female genital schistosomiasis? This often is because most health workers are even not aware that such a thing exists, because it is not part of our curriculum usually taught in school. Health workers might have heard of what schistosomiasis is. Sometimes it's called bilharzia, but the burden on females is actually not known. And even some have always thought it affects men. So because of some of these reasons, it's difficult. And therefore, most people who present within the healthcare facilities are often misdiagnosed and mismanaged. And they end up living with a lifelong complications. Some end up with infertility, some end up with some long-standing stigma. They end up losing their husbands because their husbands can no longer live with them anymore. Children lose trust for their parents because when they report, they think someone had touched their vaginal areas or they might have had sex. Most often, that is not the case. After examination, you will see that these children are suffering from female genital schistosomiasis. So these are some of the reasons why misdiagnosis is common. Next slide, please. The good news is that there is treatment for female genital schistosomiasis, and the WHO certified drug of choice is praziquantel. In most endemic areas, this drug is a program drug, and it's given to all girls and females within reproductive ages. However, if you find a case and you are not an endemic area, there are so many ways that you can get in touch with program coordinators and treatment will be given. Women or girls in an endemic area with a history of contact with an infected water source and any one of the symptoms that I mentioned earlier, such as abnormal pain, the bloody discharge, secondary infertility issues, burning sensations in the genitals. Do not think twice. Think FGS and make sure they get the treatment. Next slide, please. Some of the complications that come along with FGS include long-standing stigma. In our communities, most people are shunned. They are sometimes even thrown out of societies because of the complications that they go through. Infertility is a major issue when you come to African communities because everybody believes that so far as you're a woman, you have to give birth. But imagine if you fall prey to female genital schistosomiasis, not because of any medical condition, but just because you had contact with fresh water that is infested. It is something that is serious and we all need to take note of. Sometimes they end up with PIDs, pelvic inflammation diseases. So they go through all the systems and then we are not able to rule out all the differentials, and then people go along suffering with pelvic inflammatory diseases. In the hospitals, we see a lot of bladder cancers that are due to schistosomiasis, and especially the female genital schistosomiasis. Next slide, please. Now, how do we improve on behaviors so that we can all help end this menace within our communities and populations? We cannot take people's livelihood. For example, if the person is a fishmonger or a fisherman, we can't just say stop. But what we can do is that let's look at the reason why the people still get to the stream. There have been cases where potable water has been provided to people who are using streams that are infected, but they think it is too far from them. So it is important for us all, whilst we think about improving on preventive behaviors, let us work with the populations that are infected. Let us work with people who are affected and infected with FGS. Let's discuss with them what are the means that will work out for us. Let us not think of just going to fix solutions without the knowledge of the people. Therefore, let's provide access to quality and credible information on FGS to the people. If they do not have potable or safe water sources, let's, in collaboration with them, provide some not too far from the stream that they go to, not too far from where they live, but rather at a place where they can all benefit. Let's also help provide social norms that encourage preventive behavior. We should avoid stigmatizing people who are affected with female genital schistosomiasis and provide all the needed resources that they need. For instance, treatment should be made available. And in most countries, for now, it is free. And I think this is something we all have to try and let people know so they can go ahead as soon as they see the symptoms and go for the treatment. National programs at endemic areas are doing so much, but because knowledge and awareness is so low, a lot of people do not access these resources. We also need a lot of policy backing from authorities so that together we can help nip this in the bud. Next slide, please. Recommendations that we are advocating for include integrating FGS programs into already existing health services. Now, relevant services such as HIV health services within facilities, within communities are places that we are thinking of, that we should see how best we can integrate FGS services into it. Also, cervical cancer services, as well as all other reproductive health services. Another one that we can consider is genitourinary services. So when you come to places where genitourinary preventive care and treatments are given, sometimes you see people ending up and appearing with bloody urine. It's not something that is caused by any other infection, but it is due to schistosomiasis. Therefore, it's important for us all to be mindful of this and integrate this into our services so that we can all contribute. Next slide, please. This is the interesting part of the session, and it's about the challenge, how to create awareness on female genital schistosomiasis. All we need to do is to pen down our ideas, develop a plan to raise awareness on female genital schistosomiasis, either with an existing program, any platform that you have, or within your community. Here, a community doesn't mean traveling from wherever you are to any village. Wherever you are working, wherever you find yourself, your community refers to that particular population. So if you are within the healthcare setting, your community refers to your patients, your staff, your patient relatives, staff relatives. How are you going to engage these people in order for them to be aware of female genital schistosomiasis. So this is a challenge, and we encourage everyone who is on this platform to join and even send this message across to others who might not have had the chance to join this session, that if you have an idea, it's important that you bring it across, and there is a wonderful reward that is awaiting you. Next slide, please. So in the context, you need to describe the issues related to FGS in your country or region. Discuss the impact of FGS on your nursing or midwifery practice, and also outline the ways in which your experience could be used as a catalyst for change. All we are advocating for is for people to be aware that such a thing is real, it's existing. Over 56 million people are suffering, and we need to help end this. How do we do it? There are so many ways you can come out. Let's be innovative and pen down our ideas and enter the challenge. Next slide, please. Your solution. You need to describe your solution and the ways that your solution will help improve the situation in your area, wherever you find yourself, whether within a community, your country, or even globally. Also explain how your experience has helped you to develop this idea. So if you are a midwife, think about your experience. Have you ever met someone with some of these symptoms? I remember I came across such a case. The person was married, but it was the husband who drew closer to me because I was in a uniform. And as a health worker, you meet all sorts of people and they can come with some of these symptoms. The husband came, but unfortunately, as at then, I was just like you. I also didn't have any knowledge about it. I referred the case to Ops and Gynae, and then the case was treated as an STI. When I finally gained the knowledge, it was too late. I could not trace the woman. The man has divorced her, and it wasn't a nice scene for me. Actually, I've been having nightmares about it. I wish I could ever meet this woman to help her get treatment for this. I don't know about what your experience is. Think around your practice. Have you ever come across people with such symptoms? Pen it down, write it on paper, and then submit it. You will see the link on one of the slides, the Nursing Now website. You look for all the areas that you need to fill in, and then you submit before the deadline. Next slide, please. What are some of the steps that you need to consider? Yes, for every successful program, you need to plan. Think about the name of your community or facility. As I said earlier, your community is not just the village where you come from. It also refers to where you are working. If you are within a health facility and you are thinking of raising an awareness there, that becomes your community. The patients there, your staff relatives, and also patients' relatives becomes your community. How do you get information to these people? So think about the ways that you usually get information within your health facility, and then devise your idea around it. And I believe you will be the person to win this award. What are the reasons why you really want to take part in this awareness creation challenge? Is your project an innovation? And you don't have to worry so much. Think about it. And even if it's within 2 people, 3 people, just pen it down and then you make your submission. Do you have any experience to share? You can also list the available resources and existing interventions that you already know of. List concrete action steps with realistic timelines to enable you to achieve it. Next slide, please. And this is a guidance for you. You are required to prepare a short concept note which provides key information about you and your ideas. The deadline is 11th November this year. I think you have more time to think about it, but just as when you think you have more time, you forget about it. So the time is now. After this session, try and think about it and make your submission. The guidelines can also be found on the Nursing Now Challenge website, as you can see on the screen, nursingnow.org. Next slide, please. A cool $500 prize is waiting you. 3 months of sponsorship and mentorship sessions with you. Why would you want to wait until the deadline is over? Now, with the current economic challenges, as a health worker, I think this will be a great idea for you to take part in this challenge. Next slide, please. It is required for winners to provide a written update of about 500 words or less with visuals to demonstrate the progress of your activity by February 2023. So whilst you think about your innovative idea, it is important to show evidence. Therefore, take pictures, if there are videos, in whatever way you want us to see what you are doing. You need to attach it to your project. Next slide, please. So these are some of the resources that you can reach out to: the WHO Atlas on FGS, and the Geneva Learning Foundation. You can also find information from the FAST package and other WHO sites. Thank you very much. And at this juncture, I will call on Dr. Hamidat Omoyele Abdusalam to present the next session. Thank you. Over to you, Dr. Hamidat Abdusalam.
Thank you very, very much, Ruth, for this opportunity. And I want to say a warm welcome to everybody who is on this call right now. I am, as introduced, Dr. Hamidat Abdusalam. I'm a consultant obstetrician gynecologist with interest in reproductive neglected tropical diseases at the Federal Medical Center, Abeokuta, Ogun State, Southwest Nigeria. Next slide, please. The brief overview is to give us a very brief run through about my very first contact with FGS, my clinical experience with it, the works that we are doing on it, and then we'll focus or cone down on the Countdown Nigeria training guide for health workers on female genital schistosomiasis, which is a very valuable tool for everyone who is trying to get involved in this challenge and subsequently improving the awareness of FGS in whatever locality we are. Next slide, please. So my very first contact with FGS was in 2016. And I was then training as a resident doctor in obstetrics and gynecology at the Federal Medical Center. And well, I knew nothing about it. So some master students and Professor U.M. Ekpo, who happens to be a professor of parasitology at the Federal University of Agriculture, Abeokuta, an amazing resource person in FGS, actually approached my hospital. They were looking for a gynecologist who was going to join them on a field trip for FGS. So that was the first time I heard about it. I was like, what's this? I mean, as at then, I had already been practicing for over 10 years, and it was quite strange that there was something like that and I didn't hear about it. So joining the team, we went down to the field. I realized that I did not know what I was looking at. So I had to go back and start using my patients in the hospital and then going back to the field going back to the hospital, self-training myself. And then I realized that, oh, these lesions have always been there, really. We've been seeing them. But because we are not aware of what they are and what they stand for, we've actually been missing those diagnoses. And that was how it became something that, oh, I could actually pick. For instance, this afternoon before I came for this webinar, I was involved in a cancer screening, the cervical cancer screening exercise with the lab scientists and technicians. And it was so exciting because one of the patients that we were screening actually had what looked like female genital schistosomiasis. So because I'd already involved some people in my previous works, it was easy for them to like, Dr. Absalam, there's something that we are looking at here. It looks like FGS, and lo and behold, it was SGS. So all we had to do for that woman, instead of actually putting her through the whole, nervous wreck of, is it a cancer? Is it a dysplasia? And so on and so forth. All we had to do was write her a prazoquantel, and she actually went her merry way, quite happy. She's going to be followed up, and it's stories like this that makes it worth the efforts that we put into it, that awareness and capacity building in identification, diagnosis, and management of FGS is something that will never go to waste, especially in the tropics. Next slide, please. So we have been missing these lesions, like I said, and being aware makes it easy to develop and identify on routine colposcopy. So the challenges of colposcopy, clinically speaking now, at least since 2016 till now, the challenges we've been finding among various communities is that, one, the cost of colposcopy in the facilities is not something that is negligible. Then there is this scare that, oh, they're going to find something, and what I don't know cannot kill me. So the women are not really coming forward, except you now take it down to them in their communities to, try and make them aware that this thing is not a cancerous condition. It is something that is not sexually transmitted as at now. At least no evidence has said that. And it's something that can be treated easily with just one dose of prazoquantel. And so we've realized that the third point, which is the patient reluctance, is something that is gradually wearing down. And so we can say in few years to come, patients can come forward themselves to actually say, oh, I came for screening for a cervical screening for whatever it is that you're going to find there. And there has been reinfestation, because in most of the communities, we've actually worked in about 3 or 4 communities in Ogun State presently. The latest one is in the northern part of the state. And we realized that those we treated some years back, we go back there, and then we'll see that they have this reinfestation because the sources of their water are still the same. In fact, there is one of these communities where a borehole was sunk, but because the community was just not used to using the borehole. I mean, the whole stress of getting their borehole, because it's not electrically powered, it's manual. So they eventually end up going back to the lake, going back to the rivers to get their water. And so we have this reinfestation occurring over and over again in the communities on the field where we've been having our works. Next slide, please. So we have some work that we've done. The one we are going to eventually focus on is the Countdown training guide, Countdown Nigeria. Countdown is an acronym for calling out time on neglected tropical diseases, and that is where the training guide came out of, and that is what we are going to eventually focus on. But also from that same project of developing the training guide, other papers have arisen, which we hope to get published very soon. And most of them are directed at realizing the importance of increasing the awareness and capacity building among health workers, and how it's going to help in the identification, diagnosis, and management of FGS. Then we have an ongoing work on comparison of diagnostic modalities. We've seen that as at today, no laboratory diagnostic modality has been found to be adequately sensitive or specific for FGS. But we know that as subjective as colposcopy seems to be, if it's actually done properly, where we have 2 or 3 specialists viewing these colposcopic images, the diagnosis of FGS becomes something that is quite achievable, even in the poorest of situations. And so the Federal Ministry of Health presently is trying to assess the burden of FGS in Nigeria. It's going to be a huge project. And also the Female Genital Schistosomiasis Society of Nigeria. Fortunately, we have the president of that society. I'm the vice president. The president is also in the audience, Dr. Rabio Ibrahim. And the society was created for rallying support, collaboration, and resources for elimination of female genital schistosomiasis, because there are a lot of bodies that are involved in this. But here in Nigeria, because it's an evolving thing, a lot of us are trying to come together under one umbrella to enhance the awareness, to improve diagnosis and enhance management, because mass drug administration, which is usually what has been done to eliminate most of the NTDs in Nigeria, is mainly targeted at school-age children. The women who have female genital schistosomiasis are mostly in their reproductive age and are not in the school age group. And so they are often left out. And because these women are in their endemic, in an endemic area, being left out in the MDA programs makes it quite necessary to draw attention to this disease entity so that we can create their own MDAs that will be targeted at them. Next slide, please. Okay, so this is an image of one of our field outreaches. Like you can see, the setup is quite, it's a little bit crude, but that's the best we can do in that kind of setup. This like a journey of about 2-3 hours from the metropolis. And so we had to go there. We had to go with our own source of electricity to power the colposcope. That's me doing the colposcope and my co-specialist, Dr. Ahmed, on the site, also taking samples for pap smear. This is the current ongoing research we're having, where we are comparing diagnostic modalities, pap smear, polymerase chain reaction, and colposcopy, looking at the sensitivity and specificity. Next slide, please. Okay, so now we are focusing on the training guide, and this is the front page of the training guide. It's an invaluable tool that is adaptable to virtually almost every community or setup that we find ourselves, but it's questionnaire based and primarily targeted at primary healthcare level. It increases the index of suspicion for FGS, and it's creating a basic training guide on treatment of FGS, facilitating quick referral system. And those are the basic things for which we created this training guide. Next slide, please. So these are the objectives. If we go through the training guide, these are the objectives: to be able to identify girls 15 to 17 years and women 18 years and above who are at risk of female genital schistosomiasis, able to recognize the signs and the symptoms, to be able to treat those girls, to be able to effectively counsel them and guide them regarding FGS, reduce the stigma associated with the symptoms and the misdiagnosis. And then we should identify women who might need further care from complications from FGS, as earlier described by Ruth. Next slide, please. So in the training guide, we have an introduction to female genital schistosomiasis, something that Ruth has already gone through. And then we have the overall flow diagram of the care pathway. In that overall flow, what it's meant to do is there is a first point where you collect the biodata. Then we are proceeding to the symptomatic questionnaire where we are asking, does the woman have vaginal itching, the burning sensation, bloody urine, experience abnormal vaginal discharge, pain and bleeding during sex? And these are things that we have recorded in a kind of FGS register. So because we know that this symptoms are not necessarily specific to FGS, but any woman who has the symptoms in an endemic society should have FGS as one of the differentials that is being considered while assessing them. Then we go ahead to check the discharge color chart. In cases where there is vaginal discharge, there's a color chart that would describe from a spectrum of colors that can be seen. So because we are looking at the primary healthcare system, we have this color chart to be able to like comparison with whatever discharge we are getting. And then we go ahead and do the environmental FGS risk assessment, where we are asking questions like, do you live in an area where the source of water is just the river? Have you ever gone to the river? Do you have any direct or indirect contact with the river? And then is there anybody in your environment that is peeing and has bloody urine? And the patients themselves, we ask them whether they have had or they have bloody urine. And then we go ahead and, put all this together and come with an assessment of their risk for developing FGS. Then we go ahead and check the severity checklist. Severity checklist, where we are looking at the severity of the symptoms and the signs that these patients have. Once the severity is at a particular point, then they join the referral pathway. And if their severity is considered to be mild, they are taken to the treatment pathway where they get their praziquantel at 40 milligram per kilogram startum dose. And then they come back subsequently for follow-up to check for a solution of their symptoms and to be able to know if they are going to need further gynecological assessment and care. Then the treatment, under the treatment, we look ahead and we look at the dosing, the eligibility, because there are contraindications to administration for FGS. Then the direct observed therapy, and then the side effects, and the list of drugs that have been found to be, interactive with praziquantel. Next slide, please. So other topics in the training guide includes the follow-up pathway, those who have to be followed up when they are supposed to be followed up and how the follow-up is supposed to go. Then their health education and counseling, then the reporting and documentation in the primary healthcare system, how this reporting and documentation should be done, then supervision and monitoring of the patients and the lower healthcare providers that we have in those setup. And then we have sensitization strategy for the FGS management within endemic communities, which will be very, very useful for this challenge, for those who can lay their hands upon this document. I think the link is being shared in the chat box. And then the medications, the additional diagnostic tools for FGS, like the WHO color atlas on FGS, and then the medications that are known to interact with praziquantel. Next slide, please. So we can actually access and download the guide at this website. And I think this website had been copied into the chat, so we can click on it and then we can get the documents and go through so that we can adapt different parts or modify different parts of this document for the fulfillment of this challenge. And we can also make use of this as a template in our various communities as to what we should do in the basic minimum to be able to identify, even if we cannot afford this women colposcopy, then we can actually check them symptomatology and to see if they require further care subsequently. Next slide, please. So we can go ahead online and read about the FAST package, the FGS Society of Nigeria, the Geneva Learning Foundation, Bridges to Development, Global Schistosomiasis Alliance, and the Liverpool School of Tropical Medicine and Hygiene. These are organizations and societies who have been involved at various times in improving awareness, improving diagnosis, and enhancing management and care of women with FGS all over the world. Next slide, please. So I want to say thank you very much for your time, for inviting me. And I hope all of us will use this opportunity to improve our knowledge of FGS and to improve the care, identification, and management of our patients wherever we are. Thank you very much, and God bless you all.
Thank you so much, Dr. Hamidat Omoyele Abdusalam. We are so grateful for that update. Now, at this juncture, I would want to invite another great speaker, and she's in the person of Dr. Ogochukwu Aribodo. Dr. Ogochukwu, over to you.
All right, thank you, Ruth, for the invitation. Thank you, everyone, for having me introduced. I am Ogechukwu Aribodo. I'm a public health parasitologist, and I work in priority. Like the caption goes, FGS is my caption, the future of our girls. Next slide. Is endemic, like my colleague also explained, Dr. Hamidat, in Nigeria. Schistosomiasis was in 2021 to 2020, 2011 was carried out in the state, and some areas were seen to be non-endemic.
Sorry, it looks like there's a little internet challenge. I'm sure she'll get back to us.
Hello, can you hear me?
Okay, thank you. Welcome back.
Okay, so sorry for that. I said the target population was the school-age children as at 2019, and as at 2020, because of COVID that obstructed most of this mass drug administration, data has it as slightly above 757,000 children have already been treated. Next slide. So what are the barriers that cause this parasite to thrive in my own community? Remember, context specific is very important. If people stay away from infected water, this disease will not thrive. But in this community where we work in, that's in Achala, Anambra State community, Ntugbe, which is close to the biggest market in Africa.
Hello. Okay. It looks like the internet hasn't favored us this time. Whilst we wait for Dr. Ogochukwu to come back, I would want to remind us all that let's try and fill out the survey questions at the end of the session and submit it. And also encourage every one of us to take part in the challenge. It is very important for us all to think about an idea, looking at all the information that we have gained over the previous sessions and even today. Let's think of something and pen down our ideas so that we can take back. I'm wondering if Dr. Ogochukwu is able to come back. But if not, I think we can look at the questions again. Please kindly move to the questions so we can have a look at it. Okay, so as I was saying, let us all try and take part in the challenge. It's all about awareness creation.
Okay, sorry, I'm back.
Okay.
We're actually having some challenge over here on network issue. I'm even in the best place where we have network here. Okay, so
sorry. Welcome back. Kindly.
Thank you. Thank you. Yeah. So the barriers that the major challenge there is that people still visit this water. If there is no contact to this water, this disease will not thrive. Please, can you click on it? Yeah. Okay. And then considering the fact that these community members don't have access to quality health, in essence, they live in remote areas and they lack basic essential services. That makes open defecation a common practice in our country, especially in this area. Urination is a frequent practice, and while they are there, community members, you see them freely urinating around the bushes and farmland. And these are very close to the water bodies where this snail intermediate host thrive, contributing to the contamination of these water bodies. Next. Again, one of the greatest challenges that we encountered is that most community members worship water deities. And because this is also a nursing challenge forum, I want to throw this challenge open to all of you. How do we address this issue about worshiping of water deities? How do you tell someone to stop going to water to worship his or her God? Because even if you give them drugs, they believe that their God will heal them. So most of them don't take this drug because they believe that spiritually the water will cleanse and will not be a source of harm for them. So there you see that cultural belief constitutes a major barrier to understanding this problem linked with FGS in this particular community. Next slide. I put up this picture so you can see it was taken by us in the field, showing where they are putting their ablution for the cleansing. You can't snap them when they're inside, take a picture when they're inside the water, but they can allow you to take that because they have gotten to know that I work in their community, so they allowed me to snap it. But then cameras are not allowed within some regions, and that area would have shown you where the girls were being dipped inside the water for cleansing exercises. Now, this is a typical example how the first one shows the habitat, which you know, if you're familiar with the snail intermediate host, you will know that it thrives well around that type of edges. And these children are seen playing in this water, and this is a usual practice by them. So again, in these communities, especially in Nigeria, religious belief and cultural belief have a way of making young girls not to say anything when they have challenges with their health system. And that was my plight with this very young girl. Next slide. So like I said, being a researcher affords me the opportunity to reach these remote, hard to reach communities. So having come across this, I never knew that a 12-year-old girl could be diagnosed with FGS. In fact, when I met the girl, she was looking so innocent and could not even express herself. What made me come close to her was in the course of examining her urine, because we were there on I carry out implementation science research. So while I was in the field working, we were actually looking out for schistosomiasis in children. So when it reached her turn, she gave us her urine sample to check. But on looking closely at her own urine sample, it was already bloody. So I called her aside and I asked her, do you see your menstrual cycle? Are you menstruating? Because we made sure we excluded those people that are menstruating. She told me, no, ma, I am not menstruating. In fact, I don't even know whether I'm going to call it menstruating, because all through for like 2 months now, I have been urinating blood. So that made me pick interest. I said, okay, my dear, stay by this side, I'll look at you closely. And she bravely obliged me. But then she told me that there are things she needs to tell me in confidence that she cannot tell her mom. And then that is where the issue lies, the cultural barrier. And then the relationship and the level of knowledge of most parents in handling these issues. Because of our religion that preaches that a girl's child should not discuss anything that has to do with sex with parents. She told me when I started interrogating her, because on checking further, I was using a microscopy also, not just using the Tech kit to sieve out the egg. It was actually a quantitative research. So I was carrying out egg count. So when we checked the the urine that she passed out, we saw so many eggs. And that became worrisome. So I started talking to her, what were the symptoms she was, for her. I asked her in confidence, do you mind me taking you to hospital to look at you? She told me so long as her mom will approve of it. So I had to get involved with her parents. That took me to going to her house to seek for her, to see her on this. Now getting to her house, I found out that her mom worships the deity and she is the priestess. And then her siblings are the same, also go to the same water to worship. So I called her by the side and I tried to examine her further to know what she sees. She told me that she feels pain when she's urinating. And then I asked her whether she has known any man. And she told me no, that actually that was her fear, why she could not discuss her challenges with her mother. So I told her, how do you cope with all this, with the pain and coming to school? She told me she drinks hot water. Every time she's in pain, she drinks hot water. And then she lies to her mother that she feels cold. So you see her most times rubbing hot balm around her pelvic region because she says it itches her. So we then took her to a gynecologist with her mother's consent and her dad's consent. We proceeded to go to hospital to see a gynecologist. We, of course, in that community, they don't have any, the primary healthcare centers we have in Nigeria, not all of them are functional, including in this community. They lack basic facilities. So I had to move the girl to where she'll be taken care of. That was about 1 hour, 30 minutes. So we went to see a gynecologist. The gynecologist examined this girl and noticed that she was still a virgin. And I must actually give credit to Bridge to Development because in the course of handling this girl, I started going to internet to look at information around this schistosomiasis because her case was different. Every urine she kept bringing out was, if you put the stripe, you will see a stain in the urine. You will see that the egg, it will read positive, that confirming that hematuria is visible. The microhematuria is visible. The microscopy shows she has the egg, and she has even started having the one. She even had one that had a strange shape. That means hybridization has started taking place in that stream that she goes to bath. So we looked at her. We couldn't use colposcopy because she was a virgin. So that actually was a major challenge. But looking around her vulva, we noticed. Looking around her vulva, we noticed that she has already opportunistic infection growing, and then that was also published. We have the article published, and then I must also give kudos to Ebo et al. 2017 because I had to read their work. It helped me also in modeling mine because I looked at the girl. My challenge was I couldn't carry out colposcopy on the girl, but I could use syndromic diagnosis on this poor girl, which showed that she exhibited every symptom of FGS. And the doctor confirmed that we can actually use, on further inquiry from Julie Coxon, because I personally wrote her a mail, he told me that syndromic diagnosis can be used in place of this. So the girl was finally treated. Next slide, please. Like I said, my life was changed after that. This brings me to why this is very important. It is a collective effort indeed that we need to protect the future of our girls. These young girls, especially in these communities where people don't have basic social amenities, it will help these girls get proper health care. She could not even afford school fees. So she was not in school the day drugs were shared. So the challenge we have in this community was most young girls that should be in school miss these opportunities of mass drug administration because they can't afford school fees, and then because of taking care, most of them are caregivers to their younger ones. So they stay back in their community to look after their younger ones. I would have missed this girl out the day we came to school to look at them because she was not in school. She could not pay her school fees. So on follow-up, even after you have finished treating a patient, please, there is need to do what we call follow-up. I am still in touch with the young girl and she's now in school. She's healthy, but from time to time, she complains of having pains in her bladder. And I've been lucky to meet a wonderful lady that is speaking from her own experience, a white lady this time around, Delphine Pedebol. She has been of immense help to me in helping me to understand how these FGS patients feel. And I've been able to link Delphine with this young girl. Delphine has been talking to her, they've been friends, and Delphine has been so helpful in helping me manage other challenges that have come up. Presently, she has also located some other people that are suffering from FGS like her, because this disease does not just end up with giving them praziquantel. It has caused damage in their body. We should think beyond the damage it has caused, the drug we are giving now. We should think about saving these young girls, because now, as when I didn't notice this early in this girl child, she will suffer a lot by the time she becomes a mother. And she was still a virgin, but by the time she marries, she will not be able to give birth, as is the plight of Delphine now. So Delphine is screaming out. In her own case, she went for a water dip and got infected. So anybody can get this. Let's think of how to continue to spread the health education, and then how to make those people to understand the danger of going close to these water bodies. Above all, there is need to promote equality and equity in the delivery of health services. Please let it be our major objective. Thank you so much. Next slide. So for other, we've actually put up so many publications online that you can read. Please help paste on the link so that they can have access to it. For further information on what has been done so far by my team, please feel free to read up and then chat me up using the link I've already shared before, so that for more clarification. Next slide. Next slide, please. Okay. I won't forget to give credit to Jennifer Learning Foundation for teaching us about how to accelerate our target impact. So we made a pledge, and this was my FGS pledge. So if you don't mind, I would like you to read this pledge with me and work in line with this. I know Habitat is here and Dr. Rabiu is also here. So if Habitat and Rabiu are here, they will confirm that we all pledged to be true scholars and then take it upon ourselves to make sure that FGS does not erode the future of our women, our men, our girls and boys in the society. Because once the water is contaminated, one single person is enough to continue spreading this disease. So together I will read out, I am committed to work for a world where everyone, everywhere is protected from neglected tropical diseases, and especially female genital schistosomiasis. As a scholar, I hereby solemnly pledge to work with others to transform projects led by scholars into actions and results that will improve health outcomes. Share my success as well as my challenges by reporting on a regular basis on my progress towards implementation. And again, support fellow scholars in doing the same while upholding the highest standard of integrity and behavior. I make this pledge to contribute to the global goals for the health of women, men, girls, and boys in my country and everywhere. So this was our pledge. Next slide. This was our pledge, and it was adapted from Jennifer Learning Foundation. Thank you so much for having me here. Thank you for, and I wish to acknowledge my wonderful team. I wish to acknowledge Ruth because Ruth was also one of the FGS scholars here. And then I'm proud of what we have become. I'm proud that we are moving it forward and we are passing the knowledge on. Together, more awareness will be created.
Thank you so much. Thank you. It's so interesting that we all started from the Geneva Learning Foundation, and today we are here. Some of us are still moving on with the pledge, and I hope you, as you find yourself amongst us, will also look at the words of this pledge again and think of how best you can contribute to your society and make sure that no one suffers from FGS. It's been exciting. It's been exciting to be with you all. And we are so privileged that you found some time to join us online. And we hope that we won't end here. We are going to take up the challenge and enter our ideas, and perhaps it's going to save a lot more people's lives. Thank you very much. And at this juncture, I would want us to see if we have questions. Is there anyone who is willing to speak out? Any questions, comments, clarifications? At least we are already behind time, but we can take a question or two. Okay, whilst you are still thinking about our questions, there's FGS feedback survey that will encourage everyone to fill it and submit. There are just few questions, so please take a little time and then try and fill and submit. It's about whether you've heard of FGS before attending this webinar. If yes, give details. And then also, what was the most valuable thing you learned from this webinar? How likely are you to recommend this session to a colleague? Do you intend to take up the challenge to raise awareness of FGS? And you can bear with me, that is why you and I are here today. How will you use the information you have learned today in your practice? Would you like to learn more about FGS? Name one thing you could do with the resources you have available to raise awareness of FGS. Answers to these survey questions will help us to be able to reach out to you and also do more to help lots of populations that are exposed to FGS. As I check the chat box, I'm not able to find any questions and I don't see any hands raised. However, in case you're able to put your talk together later, you can still send it to us. You are welcome to visit the Nursing Now Challenge website and take out the form, put down your ideas and submit before the deadline. Thank you very much once again. And we are grateful for sharing your afternoon with us. Thank you and see you in our next session. Bye.
I think somebody has a question. Sabina asked a question.
Okay.
Sabina, thank you for the question. You asked whether the challenge is for only nurses.
Okay, thank you very much, Sabina. The challenge is open to everyone. So even though on the form you can see nurse or midwife, it is open to everyone. So far as you found yourself here and you have gained knowledge, you are welcome to put down your ideas and enter the challenge. Thank you very much. Are there any other questions?
Okay, to add to what Sabina asked, context matters. Like in Nigeria, for example, in primary healthcare centers, what we have there most times are community health workers. So I think community health workers also should be factored into, because people trust them more. They live in the community and they act like nurses, that are the ones that give them these drugs. So I think it would be nice if they have such people in their communities that want to participate, that are here, they can suggest solutions that are driven based on their community challenges.
Thank you very much. Also, we have seen a lot of health promoters and health educators on the platform. And these are people, a lot of people reach out to because they are usually the first point of call. They need health information and they will easily deliver. So they also share with them their symptoms, and we say you are also welcome to send in your ideas, and then we'll look at them. Are there any more questions for us? Okay, so on behalf of the Fast Packet team, on behalf of the Team Geneva Learning Foundation, on behalf of Nursing Now Challenge, we say thank you very much, and we look forward to seeing your ideas before the deadline. See you so the next section. Bye-bye.
Bye-bye.